Hello and welcome everybody to today's webinar for the FIP digital event series focused on theory to education and using change management. Specifically, we're going to talk about health behavior theories and models. I am Dr. Jeanine Abrons, and I am one of today's speakers and moderators. And I will allow my colleagues to introduce themselves as well, starting with Barry.
Hello, my name is Dr. Barry Bleidt. I'm an adjunct professor at Florida A&M College of Pharmacy and Pharmaceutical Sciences in Tallahassee, Florida. And I am so glad to be here today with you guys.
And Hoyan.
Greetings, everyone. I'm Hoyan Trong, Professor of Pharmacy and Director of Public Health at University of Maryland Eastern Shore in Maryland in the USA. I'm thankful to be here with all of you.
So we'll be joint sharing the responsibilities of moderating today's session, and we'll be responding to your chat Q&A and working with you today. So as we start today, we wanted to cover some of our introductory objectives. We're hoping that by the end of our session today, you will be able to better describe to us health behavior frameworks and models that can be used specifically in education, in advocacy, and policy for changes at a patient or a population level. We want you to know why these theories and these behaviors, frameworks, and models are important. And we're hoping that we can highlight for you some examples of how you can use health behavior frameworks and models in education, advocacy, and policy to make the changes that you hope to see in our profession. Finally, we'll discuss methods of linking some of the frameworks and impacting policy and practice change. So today we have kind of a initial format of beginning by talking more about the levels at which change can occur, and then discussing why health behavior frameworks are essential to education, advocacy, and policy. Again, going into those common frameworks and methods. And then at the end, we'll ask about your change and impact. We hope that this session, learning about these topics, helps you to create a commitment to making your own change. So towards the end of the session, we'll be asking you some specific questions, starting with this question. We'd love to see in the chat and also through this application poll everywhere, some of the countries that you're representing. And so you can see that if you go to pollev.com and Jeanine Abrons 506, and I'll put that in the chat. At the end of today's presentation, you'll be able to interact with us. And again, we're excited to see all of the different countries that you represent and hope that this impacts change management in those countries that you're representing. Okay, so as we think about this process, we need to think about what changes are we hoping to see in pharmacy. As we think about our different change management theories, we are trying to enact change at an individual level, an organizational level, and an enterprise management level. And Hoyan, can you talk for us briefly about some of the differences that you think represent in those different settings and those different levels?
Sure. Thank you, Jeanine. As you can see, we have individual, organization, and enterprise change management. There are different approaches to it. One of the things that we have to think about is among the most difficult thing to change is the change of health behavior, our human behavior. We are different at the individual level. As a concrete example, we know what's good for us. We know we have to have good diet, good exercise, but do we all do it? Do we always practice what we preach to our patients? So that's one quick example at the patient level. And then organizational change, for example, let's say use of hand sanitizer. If we see it seated, we use it at the elevator, in the room, outside one patient room to another. As an organization, how do we make sure that that is changing at the macro level, at the organizational level, that everyone will do the same thing? And last but not least, for the whole organization to change, for example, technology, or that we're adapting technology, electronic medical record, for example, for the entire organization. So these are just some example. We go into much detail, but these are just really to open. Thank you, Jeanine, for asking. We get you start thinking about what are some of the individual behavior, what are some of the organization in your organization, and what are some of the change management that can happen as we go through the different theory and models.
So we want to highlight for you some examples as we discuss our areas. And I know that when all of us as speakers were discussing information together, we were talking a lot about immunization and smoking cessation as different examples that have occurred in various stages in the profession of pharmacy. And we're hoping to do some more in future webinars highlighting how this change management theory has been applied more extensively, and really looking at what is your approach and what is your tactic to impact that change based on the level or the progress that you've made with making those things feasible in your country. During this session, we want you to brainstorm what would you like to see as more examples of services or areas that you're looking to make changes in for the profession of pharmacy in the future. And we're going to be asking you to share what are examples of ways that you're actively working towards change in your country. Okay. I am going to turn it over to my colleagues to now talk about why theories are important.
Yes, they are important. I know we're practicing pharmacists. We are involved in day-to-day operations of just practicality. So why do we even do about theories? So let's go to the next slide. Oh, because I can't change them. Yes. So theories work to identify sets of interrelated concepts, okay? And then they attach precise terminology to these concepts so that there's a standard way of discussing them. Next slide. And then theories look at how these concepts are related to each other and the specific conditions under which relationships apply to different theories. All right. So they can help us look at different types of interventions we want in our patients to help address their health problems by why are people experiencing the problems they're having? What information is needed before we develop an intervention for our patient? And then how can we best develop these interventions? And then, we want to look at outcomes. So how do we measure the intervention effectiveness? Okay. Next slide. So health behavior theories help us. How do people make decisions? Okay. How do our patients decide on what's going on? Is it their family construct? Are they maternally driven? Are they paternally driven? How is behavior generated and maintained? How can we listen to another person's perspective? This is really key as we get into one of our change management theories. We have to be able to listen to what other people are saying, and then it'll help us how to make people change their behavior. And we're talking about all kinds of health behavior. Okay. And so the theories are just a very good place to start. Next slide.
Thank you,
Now we're
Barry.
going to
Go ahead.
go for it, Koyan.
Thank you, Jeanine. If you can please go to the next slide. I won't need to reintroduce myself here, as I did in the beginning. To build on further about what Professor Barry just shared with you, have some visual image here. There are different types of theory. On the left-hand side, what we have is explanatory to explain why something happened and what can be changed about it. And as we evaluate a problem, a behavior of the individual or a situation, we also look at the change theory on the right hand. What are some strategies, some message, making assumption how a program should work. We look at that, and we also start planning to have a program to address the certain problem behavior. So it's in circle. It's a loop. Why something happened, what can we do about it, and why does it happen or not? What can we do about it? If you're interested in this resource, we provide a source for you. But next slide, please. So this one provides some concrete example, as mentioned on the previous slide, why something happened, why a problem exists. Why do people know it's important to have a good diet, lifestyle, exercise, but they still don't do it? What are some factors? That concrete example include health belief model, theory plan behavior, and precaution adoption process model. Many other theories and model. And then in terms of change theory, it provides us as a blueprint to develop what is some intervention we want to do. Do we want to provide health education? Do we want to have a public service announcement via a message on the board, on the highway, or a video, or some pictures, or some other intervention? How can we share the message? And some example include organizing a community or diffusion innovation, what Barry will talk about in detail later. Next slide, please. The population globally or in any particular country has becoming more culturally and ethnically diverse. We all travel, we working together in different country, we share different culture, different lifestyle. There are more and more data in the literature showing disparities among the different ethnic diverse groups. Therefore, it's important understanding culture and life experience so we can be a more person-centered or patient-centered care. Most of the behavioral theories can be applied to diverse cultural and ethnic group, but we also have to acknowledge and understand that there are different characteristics of each group. Some group may have higher incidence and prevalence of morbidity or mortality rate, and then the other have higher prevalence of certain behavior. For example, certain population may likely to be smoking than other, or certain population may be likely to drinking, or certain population do not drink. And then there's certain other determinants of health behavior. For example, coming from our background, our family, our parents. I always say that our parent and our grandparents love us so much that they give us everything, including the illness and the diseases. For example, my own personal family, grandfather have a heart attack. Therefore, I am at a higher risk of having a heart attack. That's one example. Next slide, please. When we're applying theories and model to provide health education and to try to change the behavior, it also helps us for change management. One particular model, the ecological model that I share with you is that an interaction, interdependence of, or factor across all level of a health problem, ranging from the individual to the community, to the organization, or to an enterprise. For example, take it at the individual level. We have friends who are likely to be smoking, using tobacco. When friends get together, they use tobacco, they smoke as well as drinking. So that is challenging because all of them influence each other. They depend on each other in order for that friendship, for that fellowship to happen, for them to be able to understand each other and share time together. It is necessary, unfortunately, to have to smoke together, drink together. That's one example. So the interaction of each other, and then not to mention secondhand smoking. I keep going back to smoking as a challenge because it's a real challenge, right? In the family, one family member smoke, the other do not smoke. But at the same time, the interaction between the dad and the children and the mom and the children will all have interact each other. Our behavior affect others, whether we get in a car and we drive safely, or we drive recklessly, or we put in a seatbelt or not. It affects our passenger, particularly our children, whether they say, oh, the driver, being a dad or a mom, do not put on a seatbelt. Why do I have to put on a seatbelt? So there are different level of influence. That's the individual level. And then there's community. If we look to the right-hand side or left-hand side, that car is going too fast beyond the speed limit. I should go fast too to keep with the flow of traffic. So that's the influence of a community, of a neighborhood, of an organization. In an organization, when one person say it is okay to do that way, it is okay to smoke inside, then the other um, member or organization will say, oh, if this person can smoke inside, so can I. So there are multiple different level, and then one organization say, oh, at that organization, the healthcare professional can smoke. So we should allow healthcare professional can smoke in this organization too. So our behavior is affected by multiple level influence. Finally, it shapes and also shaped by the social environment in which we're in. It's the condition known as reciprocal causation, right? We are in the environment in which everyone smoke. We're likely to be inhaling secondhand smoking. We're in an environment when everyone drive unsafe. We're likely to be driving unsafe because that's what everyone is doing. Next slide, please. This depict or illustrate the course of our life. We as an individual, you or me, or any one of us, are at the center, at the individual, or at a certain population. That population could be our community, our country, our neighborhood. And then there, of course, each of us have pathophysiological pathway in our body that affect us. And then I mentioned earlier, genetic. Our parents love us. They give us everything, including their disease and conditions. And then the risk that we take. Are we driving safely? Are we always putting on seatbelt? Are we smoking or not smoking? What risk do we take? Do we play extreme sport that can be dangerous? When we ride in a motorcycle, for example, do we wear helmet for protection? What are the risks we take? And our social relationship, like I mentioned earlier, among friends, what do our friends do? Do our friends take the same risk that we take? Do our friends smoke and drink? Do our friends not eat healthy? Or do our friends go to exercise? And in our living condition where we live, whether there's pollution or not in the air where we live, the neighborhood that we live, is there clean air? Is there good running water, for example? Our neighborhood and our communities, how does it affect us? Is there a pharmacy nearby us? Is there a place to go buy healthy food choices in our neighborhood, in our community? Are there places that people can go exercise? And then beyond that, in our life course and environment, we also have institution, organization. Where do we work? Do we work in an organization, an institution that support everyone to eat healthy by having a cafeteria or place to buy healthy food as opposed to unhealthy food? And then finally, what is the social economic policy? What is the policy surrounding that? Are people allowed to smoke indoor or outdoor only? Are people allowed to be able to live work or to have a lunch break, to go to take a walk, to exercise rather than sitting in front of the computer all day? Next slide, please. Socio-ecological model is a framework, as you saw, that look at the interplay between the individual, the relationship, the community, and society to understand how these factors influence health, behavior, and risk. The different level, the physical, the mental, as well as social well-being level. Next slide, please. And this one also depict or illustrate what I shared earlier, but in a different way of looking at it. Once again, the individual, based on the socio-ecological model, is at the center. We influenced by multiple level where we are, and being affected by others. And to really drive home, I will use the example of one time I encouraged the patient to quit smoking. And the patient say something that is so profound that I will never forget. The patient say, Doc, calling of me as a pharmacist, doctor of pharmacy, but he called short doctor. If I quit smoking, if I quit drinking, that means I have to leave all my friends. I no longer have any friends because all my friends smoke and all my friends drink. What do I do when all my friends hang out? When I don't smoke and drink with them, I will lose all my friends. That is just so profound. The relationship of one person with those around them. Does that mean he or she have to go find a whole new set of friends? So that is just an example. I want to share you a real life example that really drive home for me in terms of looking at this, the impact social ecological model. Next slide, please. And I want to leave you with this table for this particular section right here, different level. How do we address that? There's intrapersonal level, there's interpersonal level, and then there's community level that the institution, the community, and public policy. It always said that there's a culture. What culture are we in? What rules, what regulation? Is the institution we work at, is the environment we work at a smoke-free environment when everyone will be expected or entitled to clean air? Is an environment we working having enough glove for professional to wear and change? Have signs in front of the door that say, going from one patient room to another, healthcare professionals should change their glove or use hand sanitizer. The other example that I use that kind of really relate to the healthcare setting, we see if we go into a restaurant to eat food, sometimes there are signs that say that employees must wash hand before returning to work. Sometimes simple intervention like that in institution, just to put up a flyer, put up a sign, just to remind people to wash their hand, remind people to cover their cough, remind people to change their glove. Simple intervention like that. Rule regulation can be complicated, but those are simple intervention that can have an impact on preventing the spread of disease and germ throughout an organization. And then, of course, there are many other level, public policy, and at a different level. And next slide, please. So some example listed here for you. Diabetes management is one that involves interprofessional, multiple healthcare professional, including patient and caregiver. And then the vaccines also, where the patient believe in the vaccine. We provide some examples, some sample article for you in case you want more information on this one. Next slide, please. And I will close out with this session on the key points here that there are social determinants of health that can help us to look at different background factors. They're at the individual, at the local, national level. There are things that we need to think about. What are the goals and the rationale we try to address? What are some target population? Is it targeting adolescent? Is it targeting young adult? Is it targeting older adult? What is the intervention that we're making? And how do we know it's working? What are some outcomes and evaluation? Now, at the global level, it is characterized by treaties and agreements. Different organizations from one country to another may have different advocate to promote different things that can involve language translation, consistency, agreement. So therefore, at a global level, which is beyond individual, local, national level, it is involved. It is necessary to have treaties and agreement between different countries in order for this to happen, because nowadays, as soon as we step on an airplane within the international zone. So for example, the smoke-free airplane, people are not allowed to smoke on airplane. That is universal. Country agree that we simply should not allow people to smoke on airplane because that's unsafe. So with that being said, I will transition to the next part. But I want to leave you this one to think about as you hear all the different theories and model. What are the theories and model that can be used to plan health promotion, to plan for change management, to plan for implementation of policy in different organization and community? And once we plan, then we make the intervention. And then there's that intervention follow and align with the theory in which it explain or enable us to make the change. Ultimately, we want to improve health problem and quality of life for patients and populations. So health behavior theory model give it the evidence base that is necessary for health promotion planning as well as change management. It's not just something that I think about. There are theories and models that have been studied, that have been well documented over many years. So therefore, the applicability and the important theories in planning intervention to address health problem and quality of life. Next slide, please. Okay, turn back to Professor Berry.
Hello. Just wanted to say hello to people from all over the world. I mean, we've got people from Malaysia, Lebanon, Turkey, Peru, Argentina, the United States, Europe. We have a great group of people here, and I thank everybody for joining us. I'm going to briefly talk about Rogers' theory of on the adoption of innovation, because we're in a significant time frame of innovation occurring. And it explains how new products and or ideas are spread, okay, diffused through our profession, through society, okay. And the 5 components, as you can see, are knowledge, persuasion, decision, implementation, and confirmation of its use. So that's how we look at we read it, or we try, get knowledge of the innovation. We're persuaded to use it. We make that decision, then we implement the use of it, and then we've confirmed that we've done it. And then innovation can take form in terms of, like, it could be relative change. Is it compatible with old technologies? Complexity, all right. Observability, all right. I've been a professor, well, I'll just say I've been a practicing pharmacist for more than 50 years. I remember a significant innovation change in teaching. We went from the chalkboard to the whiteboard. Yeah, that's how long ago I was a student and teaching. Okay, my first years of teaching was on a chalkboard. Okay, so innovation. Next step, slide. So Rogers has things divided into 5 categories. Okay, innovators, early adopters, the early majority of people, the late majority of people, and then the laggards, the people who are the last to adopt technology. And not everybody adopt, you know how that goes. All right, because we still have people in horse and buggies around the world. Okay, so what I'm saying to you as a practicing professional, or as a student pharmacist, you want to be here. You want to be at the innovation as an innovator. You want to be among the first people to adopt a new technology. That way, you've become more important to your organization, to your family, to your patients, because you know you're among the first to use it. Okay, so where are you on this curve? It's good to be at the growing end. Okay, early adopter is also good. Okay, all right. So what's the next slide? So the time is now. There's new models of care going on throughout the world. I mean, WHO is going through major changes. Our country, Germany, will be going through many changes. Okay, so there's new models of care, which I'm calling disruptors, coming over as a tsunami to look at healthcare. Okay, so the time to change is now. All right, so let's look at the next slide. I want to that. What are we as pharmacists doing that the coming technology cannot do better, faster, more efficiently, harmoniously, and with better adaptability? Next slide. Think about it. And the key is, you leave it there, patients, direct human to human patient care. All right, that's what's different. That's what we have to do. People still want human to human contact, even if it's over a video screen like this. Next slide. So what's next? So if you're standing still, you're going backwards. All right, because it takes a lot of effort to maintain a forward movement. So I want you to get into a mindset that change is going to occur. You need to be part of that change. As a matter of fact, you might even want to be leading or creating that change. All right. So next slide. So there are several models we can use to facilitate change. Okay, I have different types. There's the motivational interviewing, and there's the plan, do, study, act. These 2 we're going to cover after these slides. Okay. The others are you can see there, Lewin's change management model and Cotter's 8-step change model are also you can use. But we're talking about models and we couldn't cover them all. So with that, so let's look at the next slide. So I'm going to talk about motivational interviewing. And it's based on the trans-theoretical model of change. See, again, looking at theories, all right? And the key point here is that when we're trying to change the behavior in our patients, it's a process. It's not a single event. It doesn't just happen at one time, okay? And motivate MI is what I'm going to call that. It's designed to get a personal motivation and commitment for a specific goal by exploring why our patient wants to change within an atmosphere of acceptance and compassion. And that's the atmosphere we create as pharmacists. Okay, next slide. So it's to help our patients resolve ambivalence and create an enhanced motivation for them to change. Okay, and it involves empathetic listening, not sympathetic, but empathetic, where you are understanding the person's reasons. Okay, by asking a lot of open-ended questions. Okay, then reflecting back on what the person has said so that we can help explore their own reasons for wanting to change. You know, I want to see my grandchildren grow up. So I want to live longer. Therefore, I need to change my diet to control my hypertension. Okay, next slide. So it's a conversational approach. Again, human to human. All right, this is where we are at our best as pharmacists to discover their own interest in changing. Okay, so it's a style of communication. I want you to look at those words that are around the word style. And these are the things that are, you know, we're accepting, we're respectful, we're non-judgmental. Now, I know that's hard sometimes for us as pharmacists when we see somebody very unhealthy, but we need to remain non-judgmental because we haven't, as a song said, walked a mile in that person's shoes. Okay, we don't know how they got to the point they are, and we need to be empowering and empathic. Next slide. So this is looking at the different stages of change. People are unaware that they even have a problem in pre-contemplation. This is where we are talking with the patient to get them to become aware. Okay, and then then the contemplation phase is that we've made them aware of their need to change, and they start thinking about it. Okay, so these are two areas where we're going to be spending a lot of time as pharmacists getting our patients going. And then they prepare to change, they change, and then they maintain. And guess what? People go back and forth on these things. Okay, so take a look at it. The slides will be available later. These are key steps, and this isn't, you know, we could spend a 4-hour seminar on just MI alone, and I don't have that kind of time. So next slide, please. So it's more like dancing. I'm sorry, I love this slide. You have to forgive me. It's not wrestling. You're not wrestling with your patient. You're dancing with them. You're working in concert to get them to realize they need to change. Okay, next slide. So if we have time, I might go back to some communication methods, but right now we're going to talk about 3 rulers we're going to be using, and I do mean rulers, that these are tools to enhance a person's ability to change. Here, the first ruler is motivation. Next slide. So how ready, the readiness ruler is first. How ready is this person to change? Okay. Why are you at what number? Okay. What would it take for you to go move to the next number? Okay. So an awful lot of our patients are at 0 when they're first diagnosed with diabetes or hypertension or hypercholesterolemia. Okay. We need to start moving them up to get them into a different lifestyle, to walk a little bit more, to be a little bit healthy eating, those kind of things. These are lifestyle changes that require change require us to be involved. Okay, the next slide. The next slide is, how important is it to you to make this change? And in my discussion with many patients, most of them want to live to see their grandchildren or even great-grandchildren. However, I've run into some people with some really young with problems. They'd like to see their children grow up. Okay, but how else? I'd like to spend more time with my spouse. Okay, I want to be able to travel. I want to be able to do this. So how important is changing? So you need to have this discussion with your patient. How ready are they? And how important is it to change? And then the next slide. Finally, if you decided right now to give up smoking, to become better at wellness, have better sleep habits, how confident are you that you will succeed? All right, so this is the confidence ruler. All right, and this is one of the things that we have to work on the most as pharmacists, is helping build a patient's confidence that they can change and that the change will be successful. And that's really getting into conversations with them, all right, and doing that. All right, the next slide I love. All right, now that's confidence. All right, that's what I'm talking about. That's what we need to do with our patients. We need to do that. Next slide. So the key as a pharmacist, this is our job, but we're not responsible for whether our patients change or not. That is not our job. We're not responsible. It is our job to help them decide if they want to or can change and how to do that. All right. So we're not a failure if they don't change, because we're responsible for having them decide. They may not want to change. Nothing we can do about that. All right. That's the key. Conclusion. Next slide. So you can't spell challenge without change. So if you're going to rise to a challenge, you have to be prepared to change. So regardless of what it is, there's going to be a change. Even changing what you're doing within your profession, moving up in an organization or doing things, there's a change. And it requires motivation, confidence, and that's it. So that's what I have to say about that, Jeanine. I believe that's the end of my section here. It is.
Excellent. And thank you, Barry, for helping us to think through the ways that we get motivated to make change. I will be talking about something called agents of social change. And I think that this is really important because it is really taking us through thinking about how we as individuals or those around us are the drivers of change occurring or not occurring. And so part of that process is, if we are going to be influential to others, we have to work to be conscious of ourselves. So we have to think about, how are we motivated and how is that similar or different from those around us? We need to think about, do we have different beliefs, or do we have similar beliefs to those individuals that we are trying to impact change with? We also have to think about what are our strengths and weaknesses for being an influencer. So are you a connector in pharmacy, that you really bring people together in your profession? Are you a really strong communicator? Thinking about the ways that you can be involved actively and help to impact a change is really important. We also think about something called congruence. So, how do we think, feel, behave consistently, authentically, and honestly? So, we know that in order to have change be successful over time, this is kind of a long term or a long haul approach if we're going to have it be something that's sustainable. So, we need to think about, how do we communicate those messages to the individuals that surround us in our countries, in other countries around the world in our profession and to our patients that really help them to be able to see that those are things that we are going to be committed to over the course of time. We also have to work with a collaborative spirit. We know that change is not going to be something often that is going to be in a larger scale, just one person. We're going to have to work together to identify others within the profession, outside of the profession. If we're talking about patients, to think about how patients can be involved in that process. And we're needing to empower other individuals so that they can be involved in successfully impacting a change. Now, when we're talking about social changes, these are some things that are transcending that kind of individual level, and they're going to those larger goals. So one of the things that I always think about if I am trying to impact a change is how can I create a common purpose? So this might be something that there are many other things that is a disagreement for, different areas. Maybe if we're talking about other professions, the common purpose that we share with other professions that are related to health is that we want the best for our patients and we want to enhance patient care. So let's start with those common purposes. And then we can kind of have this entry point where we start engaging in collective discussions about purpose and goals. This allows us to have something called controversy with civility. So we actively choose in this case to say, maybe we can't agree on everything. Maybe there are differences in some of our other attitudes or values or beliefs, but we can agree on this one component, and this is a place to start. So that is a great entry point into creating some of those alliances with other individuals. Now, you can see that there are some common mistakes that often occur with social change and change management. We need to think about the culture in which we're interacting and what the dynamics are in that space. If we're not doing that, we may be not paying attention to or not acknowledging certain factors which may influence the success of our change and our change management. We can come into a situation where we're trying to make change with a deficit mindset. What that means is you have to take on a mentality that I want to succeed, that I will succeed, and that I am going to identify the things that I can control, that I can work at to move change forward. If you are focusing on only the things that are barriers or obstacles, then this takes away again that potential for progress that you can make. Just like magic bullet. So magic bullet is when you decide in your mind when you're trying to make a change that there is one and only one right solution, and that this is the best solution that there is, and it's the only way to approach it. As members of a profession, as individuals that are trying to impact social change, we need to be receptive to different approaches that can make change feasible. Again, this goes back to paternalism. So again, assuming that the one approach is the best approach, or assuming that we know we need to approach things with a mindset of trying to learn and trying to really, as Barry described, think about walking in other people's shoes to be able to know what that lived experience is and why people are either open to the change or have different opinions, values, beliefs. And then assimilation is also part of that process as well. So as we look at agents of social change, one of the things that you can be aware of is that within our cultures, there are dichotomies. And so I like to think of this as kind of being a spectrum. So on one end of a spectrum of personality, we have individualism, where somebody is more focused on their individuals and goals and rights. On the other end of that same spectrum in a cultural dichotomy, we have collectivism, where individuals are focused on goals and persons and relationships. Now, it doesn't mean that when we're looking at these dichotomies that you can see on the screen, that we are solely in one end or the other. In fact, most of us are somewhere along that kind of spectrum or along that path, sharing components of both. But it does mean that this influences the way that we look at the world and the way that we look at different issues or challenges. So if I'm a collectivist, I'm going to focus first on the mutual benefit and the relationships. And then if I'm an individualist, I'm going to focus first on how this is going to impact me as an individual. Another example is thinking about universalism or particularism. So if you are a universalist in your mindset in a cultural dichotomy, you believe that the same standards should apply to everybody, regardless of the situation, regardless of the other factors that are being experienced or portrayed. Versus particularism, you're saying there are some unique nuances to that. So there are some exceptions to that rule, or there are some cases where the rules don't apply in a certain way. Now, again, as we're thinking about rules and regulations, or we're thinking about eligibility criteria or who receives a particular service or who it applies to, those can be very important things that can distinguish whether or not we're successful. I also like to talk about the power dichotomies as well, because I think that's very important. So again, when we are working with other groups of individuals to make change occur, we need to think about how do they approach hierarchy? How do they approach leadership? So we can have instances where individuals are very focused on equality and shared decision making. That will be a challenge if you are working in a context where status and hierarchies are very influential and important. So you have to acknowledge those other viewpoints, those other lenses that individuals may take on, and you have to know what your own viewpoints are in order to be able to address all of the challenges and opportunities that you see forward with you. This slide, I always think, is a great way to summarize agents of social change. So if change is going to be possible and feasible for us, so if we want to make an immunization program, or we want to have a new certification in pharmacy, or we want to expand our roles and our scope of practice, first we have to be aware of ourselves, and we have to know who we are. We have to know why we are that way and what influences us. And we have to have congruence and commitment. Again, that consistency to really work towards that goal, to work towards that change. We also are a part of a larger society, though, so we are going back and forth in our interactions with the society as a whole. And we're also a part of a larger group. So whether that is health professionals or that is the profession of pharmacy, we need to think about how we as individuals are working within the group to collaborate, how we're identifying those overlaps or those areas of common purpose, and how we are trying to say what are starting points. So if there are disagreements or there are differences in focus or approach, again, how can we acknowledge the things that we do have that are similar and use that as a driver of working towards our change? So this is just a nice scale to look at if you ever need to kind of think through that process. And again, you can just kind of do a self-assessment of some of these components that I talked to you about and say, is this something that I feel that I do all of the time, or is this something that I feel applies to me never? And again, the more important component is why. So if you've answered never, why are you feeling never? If you are saying all the time, why all the time? What has influenced you and made you attentive or aware of the importance of that piece? Now, I have some examples just in ways that agents of social change have been influential in the profession and some specific areas in case you're thinking, I've never seen this apply to our profession. These are things that, again, we can address and we can utilize to help us impact our profession and pharmacy practice and also pharmacy education. So we've talked a lot with you about a few theories and changes so far, and we're wanting to kind of pause here again to, re-emphasize this idea of why are these theories important. So as we look at some of these frameworks or we look at models and theories, they're helping us to think about the factors that we need to consider as researchers, as academicians, as practitioners. What is a barrier or a facilitator for us to be able to impact the change that we want to see in our profession? We also have to be aware that this is dynamic in nature. So, what is a barrier or facilitator at one point could evolve over time and could be something that changes over time to in relative importance. We also can use frameworks to help us think about what are the studied ways that individuals go about thinking about change or developing skills to be able to impact change, and we can become more familiar with that. Barry emphasized with you that change is inevitable. And so these frameworks are something that we hope helps to enhance your readiness and your preparedness. You can use those readiness rulers on yourself to say, how ready am I to make a change within the profession? And then we can also communicate best practices and utilize frameworks to really help ensure that we're having a higher probability of achieving the desired outcomes. Okay, and I am going to turn it back to my colleague to cover specifically the continuous quality improvement with the tool and the Plan, Do, Study, Act for change management. So Hoyan, I'll turn it over.
Thank you, Jeanine. So far, we have provided many examples as well as strategy for you. So here I want to also to invite you to pause a second and think about change in the context of continuous quality improvement. There's been a statement that say that the only thing that's constant in life is change. We experience continuous changes, sometimes changes for good, sometimes changes for hopefully not worse, but not the way we want it to be. But people also say that some people are resistant to change. Generally speaking, we do not want to get out of our comfort zone. We become so comfortable the way we're doing things, and we want to do the same way that we have always done it. So, and then we say people resistant to change, but reality is people are not always resistant to change. They are afraid of change. They can be scared of change because change brings uncertainty, especially when a lot of change coming at the same time when we have so much changes. That can be concerning. So how can we put it in a positive way so that we don't have the statement that if we always do the same way, we always have the same result? Meaning sometimes the way we do is not the way we want, but it just has always been done that way. No one thought about changing it because either A, they afraid of change, not resistant, afraid of change, or B, they do not know how to change. So we have to have continuous quality improvement for any program, project that address, patient health improvement or the improvement of the health of the entire population. How can we make change gradually? Same thing, the concrete example in patient is when we change all their medication, how do we know which one work, which one doesn't work? Especially when it comes to combination therapy. When a two agent in there and we change, how do we know whether it's medication X or medication Y that improve the patient health outcome? Therefore, that is one of the disadvantage of combination therapy. So how do we approach change in a systematic way that people can be comfortable to make changes? So I want to share with you a tool for continuous quality improvement. Even if we do well and we don't change, like Barry mentioned to you earlier, If you don't move forward, you just stand still, you are in a way going backward because things are moving forward. So one example to do change in small increment, a systematic way is the PDSA cycle, Plan, Do, Study, Act. It's a very simple yet a very powerful framework for accelerating or speed up the improvement in an organization, in a project. It is very compatible with other model out there that people may be using that can also help accelerate improvement. There are two parts of this. One part is the fundamental question that we ask, right? We ask a very fundamental question about the changes. The first question we ask is, what are we trying to accomplish? What is our goal? So once we agree on as a team, as an organization, what are we trying to accomplish? What are we trying to change? Do we want to have better process for patient care? Because remember, it's not always about the outcome. It's about the process. It's not just whether we can help patient to treat diabetes, to treat hypertension, but their patient experience, the holistic approach, right? We'll not just look at economic outcome, but humanistic clinical outcome, but also humanistic outcome. Are the patients satisfied during the process? So the first question is, what are we trying to accomplish? The second question, how will we know that a change is an improvement? How do we know it's a change for good and not change for worse? And the third question we ask is, what change can we make that will result in improvement? How can we be sure? In order to answer those three questions, in order to apply a systematic approach that we have, we look at the cycle called the PDSA. And thank you. PDSA is a systematic process. It's a cycle, continuous cycle to gain valuable learning and knowledge for the continual improvement of a product, a process, or a service that we provide for our patient or our client in case the individual is not a patient. This is very important because it was first introduced by Dr. Deming and a mentor. The cycle begins with the plan step. It involves identifying the goal or the purpose, formulating a theory, defining success and metric, and putting plan into action. What are the things that we need to do? What are the things we have to plan for? After that, we start doing things. After we plan, similarly, the analogy I would draw is you come up with a list of problem of the patient, whether it's a first drug reaction, drug-drug interaction, or in the case of a population, what are the problem? People not washing their hand, people afraid of getting vaccine because of their first effect. What is the problem? How do we address that? Once we identify and plan for the change, we start doing it. The do step is which are we implement, such as we're making a product, we do it differently, we test it out. So most of the time, it is recommended we do pilot tests, small incremental, so that way we don't waste resource, whether we know it's working or not. After we plan and we do, we have to study or evaluate where the outcomes are monitored. Whatever we're doing, is that working or not? We have to pause and evaluate. In the case of patient care, we look at the patient for efficacy and toxicity. Are their condition improved? Are they having minimal side effects? So that we're looking at in the case of a population, do we have a reduction in the breakout, the prevalence of new disease? Do we have a population who's healthy when most people are not overweight, when most people are exercising? So we look at the study small at a time. And then finally, after that, then we act. The act close the cycle, integrating the learning that we have done, we have learned about the entire process that can help us to adjust the goal, the change method, whatever goal we set is a realistic goal. I also pause here to remind you when we talk about planning and goal, we also talk about SMART goal, right? The goal have to be specific, measurable, achievable, realistic, and time-based. So that's doing the plan. And we go back to the plan. Oh, it's working well. So we pilot test in a small group. Let's expand it to be a larger group. Let's expand it to the entire community. Let's expand it to the population. So this is a cycle that can be continuously used. Although the action step, close the cycle, integrating everything together, but we still have to have continuous quality improvement. These steps can be repeated over and over of a never-ending cycle. And here you see, this is a never-ending cycle. We adjust it, and then from the standard, and then we go back, we make continuous improvement. Because once again, there's always a need for improvement. There's always room for improvement. Whatever we do, we think that's good, that's best. tomorrow with new factor, with new medication coming out, new disease outbreak. It's important to do that. Another technology come out to help us. We need to continue to improve to move forward. And this is actually a scientific method of change, right? To improve the quality of the process. Once again, sometimes we focus a lot on the outcome, but we forget the process, the step to take there, as if this more simple say it's not what we give the patient, it's how we give the patient, right? The process is important. We want patient and the community to have good experience. We want them to have the positive experience. That humanistic outcome is very important. That, it's not that the end justify the means when it doesn't matter what the outcome is, as long as we do it and we get the outcome, that's what we want. And in that case, we'll lose all our friends along the way. We lose our partner, our collaborator, and we also lose our patient and our population. So therefore, it's very important to take incremental step, small change, utilizing the Plan Do Study Act to make small graduate change in an organization. Next slide, please. I believe that wrap up this part. I turn it back to you, Jeanine.
Thank you, Hoyan. I will be kind of closing out some of this discussion by just really emphasizing the importance of recognizing and knowing whether or not a specific approach is appropriate to a culture, to a language, and to a context. So there is a framework or there is an approach that is primarily used in the US, but I think it applies to really a lot of countries as well, that really says, as we are creating an intervention, as we are designing something for practice or for academics, we need to think about what are different cultural variations from what we've seen when a tool, an instrument, a model has been applied to a culture different than our own. So that can mean that we need to take a moment to understand how are the motivations different, or are there different health beliefs that need to be taken into consideration that influence individuals in their health behaviors or their actions. We also need to think about the importance of rapport. And so, as Hoyan mentioned, really, in order to be successful in making a change, as Barry talked about with empathetic listening, we have to create a ongoing rapport and trust with our patients in order to be able to be an influencer and to be effective in our advocacy related to change. And then we need to think about what is important in that cultural context to make that change stick. So, are there things that are drivers of that consistency, that ongoing commitment, or are there more temporary factors that exist as well? So, we've covered a lot of different approaches with you today. And we have tried to give you some ideas of frameworks or models that you can apply to making and impacting change wherever you are in the world. But these are just a few examples of the many different examples that are out there. So you can see, again, a approach that involves shared values, structured systems. You can also see an example where we look at awareness, desire, ability, and reinforcement. We mentioned briefly that there is Cotter's 8-step model, and you can see some of the components of that, and Lewin's change management template as well. What we want you to take away is there are many things to guide you in your approach to impacting change. And there are many things to help you identify which factors you need to consider or which lessons other practitioners or other academicians have also learned over time. And you can utilize those to be more effective in impacting that change that you're hoping to see for pharmacy. Again, another example is 7 Habits of Highly Effective People. So there's a ton of things out there that are really great examples that you can utilize. But what we hope you have taken away from today's session is that these health behavior frameworks can be used, and you can apply them in many different facets or fashions. You can apply that to education, to advocacy. You can apply that to impact policy and change. You can think about patient or population levels. And we hope that we really have emphasized the importance of this in helping you to proactively identify the different factors that might be important in being successfully a member of the profession that is able to drive practice change. In the future, we'll cover more on how these theories and frameworks apply to specific types of change. Again, giving you examples of different areas in the profession where the models have been successfully used to explain the different factors that are impacting the situation. And so I'm going to back out and I'm going to go to poll everywhere, and hopefully we will be able to see these different responses. So the first thing that we would like to know from you is we would like to know what change has this session helped you to commit to making. And so again, you can go on your phone, on the web, to pollev.com, to Jeanine Abrons. You can also type for us in the chat if you're having trouble with the technology, to let us know what are some changes that you are feeling committed to impacting based on our session today. Hopefully our technology will work for us. So we'll go back. Hey. Looks like the technology is just being a little bit slow in connecting, so we will switch to the more manual way for today's session, and we'll give it a try again. Again, this is a great example of when we are trying to impact change. There are many things that can influence whether or not that is working for that moment or for that situation. And again, we just continue to try to work things through. So please type in the chat for us, what are some different changes that this session has made you committed to changing? Oh, and yes, we can also type in the chat as well, the poll everywhere for you too. And I'll go back to the initial slide. So here we go. Okay, if you have a phone, you can scan your QR code and you can go to pollev.com and then / Jeanine Abrons, Jeanine, Abrons, Abrons 506. You can also type in the chat for us some of the changes that you want to make professionally. So I'll leave this up here for a minute before I switch back over. Now I'll ask my other colleagues, Hoyan, Barry, what are some changes that you have seen most recently in the profession for things that these theories or these areas have really applied for or applied to? And I'm seeing a few components that are there. I'm seeing that we have Christina, who is commenting in our chat too for us. Thank you, Christine. She's saying identifying and developing continuous pharmacy education for pharmacy team members with more specific relevance to post-learning evaluation at the moment of learning And again, hopefully you can kind of see this right here, right at the top of my screen, polev.com/Jeanine Abrons 506 is another way to share your responses. I know one commitment that I continue to try to make professionally is, again, very specific to what Christine is saying as well, thinking about how are we impacting that change, how are we helping to provide education for the opportunities that we're seeing. So some of our responses so far are more person-centered care, applying theories to work, thinking about patient motivation for change, and using agents of social change within our research. Thinking about how we are educating students on change opportunities and using behavioral models to understand patients' readiness for change. Those are some great applications to thinking about change. We'd also like to know what are some ways that FIP can help you make this change? So again, is that through training? Is that through webinars or tools or measurement scales? What are the ways that FIP can help you to impact those things that you're hoping to see in our profession? And again, we are thinking as we move forward and as we try to impact change within our profession or enable that as well. We want to make sure that we are providing the tools, providing the structures that can help you to be successful at whatever you want to accomplish. Okay.
Hey, Janine, there
So,
is oh, I'm sorry. There's a question. I think there's so many things in the chat that I had to scroll back to catch. I think there's a question,
oh, yes.
a very interesting question near here. It keeps jumping, so I have to scroll back a little bit, and it's still jumping. People type actively in the chat box, which is great. The question is, what do you do when culture and the desired change do not match? That is a great question. We all know culture. I will attempt to share my perspective, and perhaps
Yeah.
Neil and Barry, you can share also. And we invite other attendees to share through the chat also. So certainly, I acknowledge that culture and design chain do not match. Uh, I would say that culture is very important. The way we do things in the culture, it goes back to what I shared earlier about the social determinants of health, the culture, the environment. We have always done it that way. So my first step to that is to identify and acknowledge. Like I mentioned earlier before, people are not resistant to change, but they may be afraid of change, or they don't know how to change, or they lack information. So the first step I would suggest, when we feel that the culture and the desired change do not match, to have a conversation, to have open dialogue, to learn more and understand why. Why is the culture that way? Why people not wanting to change? And perhaps people just need more information. They're afraid of the change. So once we're able to identify why it's like that and understand that culture, I feel like culture is very important. And I share this example with students all the time. While I teach at one institution, sometimes I go in a guest speaker at another, or an adjunct faculty in another, then I always get to know that institution. Similarly, when I work in one pharmacy, in one independent pharmacy back then before I joined academia, I go in the pharmacy, I tell technician, share with me the culture in these places. Yes, I may be a pharmacist, but the technician, the assistant in the pharmacy, know better the culture than me as a pharmacist. I cannot walk in and say, I'm the pharmacist, this is going to be my way. That is setting myself up for being arrogant and failure. So I learned first, I'm a pharmacist, please, and I tell the technician, please help me learn the culture. Similarly, I would say that if you ask to see what is the culture in country X, Y, and Z, organization X, Y, and Z, this will involve organizational change. So I think first to do is understand the culture, and then after that can discuss how can we change slowly, and it had to be in small increment, pilot tested, so that way people don't feel like they lose all of the experience that they have, right? So small change is good. it's just one's perspective. I'm sure that Barry and Jeanine have other perspective, and other people feel free to share in the chat also.
Yes, Hoyan, I think I go back to that whole finding the common ground and also having controversy with civility. Maybe there are some differences that we have culturally where the change doesn't align, but what does align with the culture? What is our starting point? Where can we begin? Because again, sometimes as we find that entry point or we find that point of discussion, we can find something to direct our focus in that manner, or we can say, yes, maybe this is something that we're seeing differences with this belief or this value, but this is a belief or a value that this aligns with. So giving a place to start is really important. There's many times that we're not going to be in agreement in absolutely everything that we want to see, especially when people are adjusting or they're in that level of pre-contemplation, as Barry said. But as we progress throughout, as we give people more exposure, then I feel like oftentimes people will identify ways that it does work for them or it doesn't. Hoyan also talked a lot about the importance of cooperation and allies in making change management. And I think that's a great example to say recognizing your limitations in different spaces and really looking to have somebody that can be an advocate with you to be able to impact that change. Great point for us, Hoyan.
I'm also going to say sometimes people have this fear and these worries, but I've watched people in the cultural change become a leader in their culture to lead the change among their culture or their friends, as in the case of Hoyan. Wow, you're taking a smart move, not smoking and drinking anymore. Maybe we need to maybe cut back, or maybe we need to do this, Hoyan. So sometimes it's a matter of helping them stand up and say, you can be a leader and making these changes because this is what's best for you. Okay.
I love that. I think that is really important to think about what is best for that individual or what is best for that situation. Excellent. And thank you. I see many of you have shared in our poll everywhere as well your commitment to being involved in future change management, which I think is incredible. I see some comments in the Q&A where individuals are saying that they're resonating with the relationship of the pharmacist for the patient and suggesting the inclusion of the change that's needed for the pharmacy team, for the community health workers, for the patient navigators. I am seeing a comment, and maybe Hoyan and Barry can comment. Could we talk about some sources that provide information on successful implementation of behavior change amongst patients and prescribers related to antibiotics?
Oh, wow.
And I can take that if you want
No,
as well.
that's really taking a change literally, and that is making a change in the practice. There's a lot of information on antibiotic stewardship at FIP has that is at the American Society of Health System Pharmacists websites, American College of Clinical Pharmacy. I believe that even the Asian College of Clinical Pharmacy has some information resources on their websites for this.
Yes, looking for those antibiotic stewardship resources and toolkits. And Barry mentioned some of the different organizations that have those can be very valuable and influential. You can also look at the Infectious Disease Society of America, and they have some antibiotic stewardship toolkits as well. I'm also seeing a question that asks us similarly on resources for oral health bad habits. And one of my practice sites over time has been a college of dentistry. So I would say that that is a great example of looking for allies or looking for other professions that have maybe done work in this space before us. If it's something that our profession has not started with, dentistry has a ton of really great resources for oral health and for having those conversations as well for smoking cessation. So if there's something that you can't find in our profession, one of the things that I learned in graduate school is to go to a related profession and see what they have. You don't have to start from scratch if it's an area where we haven't focused on that before. So it looks like we are towards the end of our discussion time. Thank you for all of your amazing comments in the chat of encouragement for the sessions. Again, these are some things that we hope to continue to provide you. We have included at the end of our presentation our contact information. And so if there are any questions that you have that continue to be present in your mind after you view this presentation, I will put that slide back up on the screen. Again, we would love to continue to work with you for the future to help involve you in this work. And we would love to get your perspectives, get your involvement in the long run. And so, again, we want to leave you today with this idea that you can be the change that you wish to see in the world. We hope that you continue to engage at whatever level you're able to, whether it be with FIP or it be professionally in impacting change. The more individuals that we have involved in trying to impact the changes that we make lessens the load and makes that light or that work a lot lighter. And again, you can feel free to share your email or to email us to be involved, and your involvement can ebb and flow over time. That is something that we absolutely want to understand and acknowledge that we understand in getting individuals active within FIP in the profession.
Yeah, and if we have enough of a demand or request, we can do a workshop on one of these topics in more depth, like motivational interviewing or one of the other topics, and really go into depth and do some hands-on exercises so that we can help with the oral health problem or those kind of things. So love having everybody here from around the world.
And again, we want to sincerely thank all of the rest of the speakers. Thanks to FIP and the academic section for allowing us to share our wisdom and expertise today, to be involved in today's presentation. Here is our contact information again. We look forward to continuing to interact with you, and please feel free to help us to be able to impact the change that you want to see. Thank you, everybody, for such a great session, and we hope to see